This is an important study. The background is that after we organized these networks and we're developing our own studies, NIDCR came to us and said, look, there's this important issue with osteonecrosis of the jaws that we're seeing, and we need to do something, and we think the networks may be the best way to do something in relatively short order. It turned out not to be as short order as we thought, but we did a really good study across the 3 networks. And so what we want to do now is see the results from all 3 networks. And to present that, Philippe Hujoel is a faculty member at the University of Washington. He has been working with this osteonecrosis of the jaws project since its inception. He helped design the study and oversaw the collection of data from our end of it. So we're going to invite him now to give the presentation, give the results from the combined 3 networks on this study. So Philip.
Last week we were all at the ADR meeting and we presented these results, and one center kind of focused mostly on the biology, the other center, which was us, focused mostly on the design, and then New York, Pearl, focused mostly on the results which I'm going to present to you today. So what you get to see today are the slides, the analysis which were done by New York. So I'd like to say it's live from New York, but it's not. Rick is not here. But I'll try to do my best to present the data. So I'll mostly show you the data and kind of show you what the results were across the 3 networks. Here you can see our total number of cases. So we had 191 ONJ cases and 573 controls. Roughly 25% of that, 1/4 of that, came from the precedent, from the 5 states from our network. This is the way it was planned. From the very beginning, if you remember a long time ago, 5 years ago, we all sent you a survey asking you how many cases of ONJ you roughly see in your practice, had seen in your practice in the last 2 years. And based on that survey, we decided that the number of cases we could recruit here within our network was roughly half of what the other networks could do in terms of sample size recruitment. So here you see a distribution of the cases by practice type. And so on the very right here, you have precedent. And the thing I would like you to notice is that in our network, the majority of cases, 83%, roughly 4 out of 5 cases, and almost all the controls came from general dentistry. In other words, came from providers, from DDSs that are not secondary care. This differs quite a bit if you compare it, for instance, to New York. If you look at New York, their majority of cases, roughly 60%, came from tertiary care centers, faculty practices. The DPBRN is kind of in the middle, where still they have a majority of cases coming from general dentistry, but they have quite a few more cases from secondary care specialists, oral surgeons, and other specialties, which in some cases include periodontists, oral medicines, etc. So our network was quite unique with respect to that most of our cases came from general dentists. Couple of data related to the lesions that were diagnosed. So on the very top, you can see the maximum size of the lesions. Dime or smaller, quarter. Roughly 70% of all the lesions in the networks were small lesions, quarter-sized or smaller. So these are very different cases than the ones you will see sometimes in the journals, which represent kind of these massive osteonecrosis cases. So our study is not on that type of osteonecrosis. It's on the very small lesions. And as some of you may have seen, these small lesions sometimes are kind of like the tip of the iceberg. If you take a CT scan on those patients, you can see that the necrotic bone is actually the whole mandible, but there's just this one tiny little piece that's starting to peek through. So the area of exposed bone healed at the time of the patient interview, 36% was yes. Most of the patients, the majority of patients, they had an active lesion when they were being interviewed. And one of the entry criteria, if you remember, in our study was that they simply had to have exposed necrotic bone. We did not provide a time period that it had to be present. Some people say necrotic bone needs to be present for 8 weeks before you call it osteonecrosis. Some people say it has to be present for 3 months. So we did not specify any time. But you can see that the majority of our cases, 60% roughly, had exposed necrotic bone for more than 8 weeks. The year of diagnosis, originally we had said the diagnosis had to be made after 2005. Then we relaxed the entry criteria to get to our recruitment, and you can see a small 12% was cases that were recruited that were the year of ONJ diagnosis was 2004 or 2003. Most of the patient had one quadrant involved, 75% of them. And the next thing here is an interesting thing which I presented last year and seems to be confirmed across the 3 networks in the sense that a lot of patients, roughly 1/3, have a tingling in the jaw before, they have neurosensory disturbances before the actual onset of the ONJ lesion. And for the majority of patients, the lesion is painful when it becomes exposed. These are the medications that practitioners use across the 3 networks. You can see that the majority uses medication to try to manage the ONJ. 72% of people reported that they were on medications to try to manage the osteonecrosis of the jaw. By the way, the PQ you see here stands for patient questionnaire. So these are data that comes from the patient questionnaire. And the type of medications that people use to try to manage the osteonecrosis of the jaw include systemic antibiotics and chlorhexidine rinse. Those 2 are the most common types of medications. I was kind of surprised a little bit to see that 1 out of 5 is on narcotics to try to manage the pain. And so now I'll start to present kind of some of the results. What factors are associated with osteonecrosis of the jaw? Here we'll first start with some socio-demographics. This data also comes from the patient questionnaire. You can see that gender is not associated with it, race is not associated with it, but age is. If a patient is older than 60, he is at an increased risk for having osteonecrosis of the jaw. So the older one gets, the higher the risk becomes to develop these types of lesions. Education was associated with it. If you look at income measures of socioeconomic class, it's a pattern that you see for a lot of different diseases, that the lower the education, the lower the income level, poverty were all significantly associated with osteonecrosis of the jaw. From an epidemiological perspective, that means that a lot of other things will be associated with osteonecrosis of the jaw, such as, for instance, cigarette smoking. One of the things we were interested in was oral hygiene. Probably since the 1800s, they have been recommending that the best way to prevent osteonecrosis of the jaw is to have good oral hygiene. One of the very first public health legislations that was done was that industries that were in the phosphor business had to post on their walls guidelines as to how to brush their teeth, rinse your teeth, etc. So these really are the first data to assess whether this recommendation provides a benefit. Is there really a reduced risk for osteonecrosis if you have good oral hygiene? And it's kind of going the opposite of what we expected, but nothing is significant, basically. You can see that brushing less than once per day, there is no association between. If anything, it's a little bit a lower risk. By the way, when you look at these data here, if you look at them in your handout, we don't have enough time now in these 20 minutes to go over it, but these data in the controls should be, you should compare to, how do they compare to your practice? So here, for instance, for brushing, we have 4.2% of the controls that report that they brush less than once a day. So you as a clinician, me as a clinician, should kind of look at this number of 4.2% and say, okay, that makes sense. In my practice, that would be roughly the percentage of patients that says that they brush less than once a day. So here, if you look at flossing, which is also not related to osteonecrosis, roughly 36% of the patients report that they floss once or less per week. So if these numbers, don't make sense to you as a clinician, it's something to take note of in the sense that it may be related to the practice type, one of the first slides that I showed you, why you will see some things that kind of may seem unusual at first. Smoking history is associated with osteonecrosis of the jaw. whether or not that's related to socioeconomic class or whether that's indeed, or whether, for instance, the smoking is causing a cancer and the cancer then subsequently is leading to the use of bisphosphonate. Those are questions that we'll go into later when we present multivariate analysis. Here are some data related to the dental history form. So these are data that were abstracted from your charts when we asked you questions related to the patient. You can see that gingival bleeding was not associated with osteonecrosis of the jaw. Here you see a very interesting finding and this is a finding that keeps coming back, suppuration is associated as a sign for ONJ that's going to start. So if you see a patient that is suppurating and maybe there's also neurosensory disturbances going on, it should be kind of a warning sign that there may be an osteonecrotic lesion going on in that area where there is suppuration. Endodontic problems is something quite interesting too. There is a significantly elevated risk with endodontic problems. I think it kind of fits with the neurosensory disturbances, the feeling of a heavy jaw. There is pain there, so there will be notes in the charts that there were endodontic problems prior to the onset of ONJ. Caries, no association. If you look at endodontic problems, one thing which kind of surprised me, for instance, that 1 out of 4 controls reported endodontic problems, which to me seems high. Extraction, you can see that extraction, matched extraction, meaning an extraction that happened in the site in the quadrant where the osteonecrosis developed, is a very big risk factor for ONJ. Periodontal surgery, which was relatively infrequent, was not a significant risk factor, but given the low prevalence, we really didn't have a lot of power. So one should not see this as a green light, that, okay, periodontal surgery is not a risk factor. Given that only 2% of the patients in our population had periodontal surgeries, basically we don't have any power to detect whether or not periodontal surgery in this instance is or is not associated with future onset of ONJ. Endodontic treatment. You can see that endodontic treatment is also associated with onset of ONJ. So these are all treatments that were delivered prior to the onset of ONJ. So when we started this study a long time ago, the ONJ experts were telling us these kinds of stories, basically, that patients come in, they have a heavy jaw, you don't see any symptoms of osteonecrosis of the jaw, they complain about a toothache, they have all these symptoms going on, and it's later that really the osteonecrosis develops. And the data that we collected across these 3 networks confirms what the experts were saying. Implants is an interesting one. You can see was marginally significant. You had roughly an 80% increased risk for ONJ development after placing an implant. But once again, look at the prevalence of implant placement in this population. It was roughly, if you look at matched and mismatched, roughly 6%. So we really didn't have a lot of power to find out whether implant placement is or is not associated with the onset of osteonecrosis of the jaw. Here we see some other very big risk factors. One of them is having a cancer. And you can see that the odds ratio is quite significant. There is a 14-fold elevated risk for a patient with cancer to have an ONJ onset. Prostate cancer was not associated. Breast cancer was associated. Multiple myeloma, the association was so big, basically, the model failed to converge. They could not get an estimate, but multiple myeloma is a very strong risk factor. It's one of the cancers which is most strongly associated with ONJ, and the reason is that it's one of the cancers that they use bisphosphonates quite extensively. And then other cancers, you can see any type of cancer basically seems to elevate the risk for the development of ONJ. And at the very end, I'll show you some data where we look at patients that do not have cancer, and you can see that in patients that do not have cancer, bisphosphonates and extractions are still a risk factor for osteonecrosis of the jaw. Osteopenia, osteoporosis, 2 conditions which are associated with the use of bisphosphonates, both significantly elevate the risk for osteonecrosis of the jaw. Diabetes, there have been a couple of studies that suggest it was not associated. In our study, we did see an elevated risk for osteonecrosis if a patient was diabetic, and also anemia was associated with an increased risk for osteoporosis. Notice here in the controls, you have 16.2% of the patients have anemia. So my personal kind of interpretation of these data is that it's in part due to the fact that roughly 1/4 of the cases come from tertiary care centers where there may be a lot more patients with systemic diseases with anemia. But I think in general practice, I don't think the prevalence of anemia is that high. Here we get to the biggies, the big risk factors for osteonecrosis of the jaw. Bisphosphonate use. This is a humongous risk here. It's a 300-fold risk increase. From an epidemiological perspective, this is pretty rare. If you think about smoking and lung cancer, the relative risk is about 10. So to have a relative risk and odds ratio of roughly 300 is just an indication that this is an unequivocal causal factor in the onset of osteonecrosis of the jaw. So this elevated risk of 300 is associated with the intravenous bisphosphonates. If one just looks at the oral bisphosphonates, which we're more likely to encounter in our practice, the odds ratio is approximately 10, which is still a very sizable increased risk for developing ONJ. Duration of bisphosphonate use, you can see that even very short-term use of bisphosphonates was already associated with a significant 13-fold increased risk for osteonecrosis of the jaw. And then there's different chemical classifications of the bisphosphonates, and it looks like if the nitrogen is in the ring as opposed to the chain, those are the types of bisphosphonates that are most strongly associated with the onset of osteonecrosis of the jaw. So here you can see some of the more commonly used bisphosphonates with the oral. You can see Actonel, Boniva, Fosamax, Fosamax. The odds ratio is approximately 10. These are the IV bisphosphonates, Aridia and Zometa, and both are associated with a substantial increased risk of osteonecrosis of the jaw. Yeah? Why is the p-value different for all these different percentages? It depends on the prevalence of use in controls and in your cases. Depending on the prevalence in your controls, you may or may not have more power to detect something, and it may also reflect in part on the strength of the association. In other words, it may be, p-values p-values reflect on different things. One is the prevalence of the conditions under use. The other one may also be related to the strength of the association, that higher p-values, in part, not always, may reflect a stronger causal association. Yes?
Is there a place where we can find which drugs are nitrogen chain ring or non-nitrogen?
No, not in these handouts. Oh, but you can find on the web, but it's right. Any other questions? I'll go relatively quickly here over oral steroids, significantly increased risk, chemotherapy, significantly increased risk, radiation therapy, as one could expect, increased risk, hormone replacement therapy not associated with an increased risk. And now I'll present you the multivariate analysis where all these different variables are combined and one tries to pick out which one are most informative for us to make a decision as to whether they're really associated with an increased risk of osteonecrosis of the jaw. So this analysis is limited to 136 cases and 364 controls. And you look at bisphosphonate used, which is defined as non-oral or IV. And you see what ends up in the model. In other words, which factors of all the ones that we went over are associated with osteonecrosis of the jaw. Suppuration is very strongly indicative, a predictor of osteonecrosis of the jaw. Extraction is significantly associated. Radiation is significantly associated. And then bisphosphonate use. Both the oral, people that just take oral bisphosphonates, and if you look at the IV, basically the odds ratio is too large to be estimated. And I'll show you one last slide which may be of interest. This is the slide which is limited to patients that do not report having a cancer. So which factors in those patients that don't have cancer are associated with osteonecrosis of the jaw. And you can see that once again, separation seems to be a very good predictor for the future onset of osteonecrosis of the jaw. Extraction remains a significant predictor also for the onset of ONJ. And then bisphosphonate use is significant. So I think one of the things that this study established is that for those patients in our practice that don't have cancer, that are not on intravenous bisphosphonate, that are taking just Fosamax, they do have an increased risk for osteonecrosis of the jaw. It significantly elevates them. And the other thing that I kind of think may be useful for clinicians is that separation, neurosensory disturbances, complaints of pain without any symptoms of ONJ in a patient that is on bisphosphonates may be kind of a warning sign that there may be a silent case of osteonecrosis of the jaw going on there. So I'll open it up at this time for any questions you may have.
So if you suspect ONJ, what do you do? Like, what tests do you do to find out?
One of the interesting things I've seen is when you take CT scans, you can see the extent of the osteonecrosis of the jaw, and as a clinician, it may be useful in the sense that you may see just a tiny lesion, like most in our study have these tiny lesions that are smaller than a quarter. But if you take the CT scan, you may realize, oh my God, it's really extending all the way across, and I have to be very careful even if I work remotely from that area.
So what is the clinical feature that you see radiographic feature you see in a CT scan?
It's deposition of bone. It's basically new bone formation around the mandible that kind of extends all the way around.
Is there a theory that this symptoms is a misdiagnosis of endo that is, or a pre-osteonecrosis symptomology?
It's a great question. I mean, I don't think we'll know the answer unless one can do histology or anything like that. It looks to me like there is really neurosensory disturbances, pain, heavy jaw going on. And I think if we don't think about bisphosphonates and you have a patient come in and maybe there's already a lot of restorative work, it's easy to think, well, I think, you're starting to have a root canal problem on this or that tooth. Let's try to do a root canal treatment. Then, it may or may, likelihood it doesn't solve at all the neurosensory disturbances, but it's basically kind of an attempt of us to try to manage the situations and only afterwards finding out, there was something more sinister going on than just a pulp pathology.
Doctor, could you briefly, over here, you briefly describe the treatments for ONJ, specifically hyperbaric oxygen and their effectiveness?
It's really completely out of my scope as far as my clinical expertise. I've heard when we were at the ADR meeting, there is several people trying to do hyperbaric oxygen, but some of the early reports suggest patients may be worse off using hyperbaric oxygen. So that's one thing I heard at the ADR meeting, but it's outside of my scope of expertise.
One more question, and we have to cut it off in back.
It's on the same mode. Do you have any plans to extend this to treatment modalities that have been applied to these patients in the study, to continue the study?
No, that is not part of the plans.